Hello, Assalamu alaikum. Can you people hear me?
Yes. Can you
Uh,
hear us?
yes, sir. The next case that we have is of a 52 years old male patient who presented to us with pain and hypochondrium and on and off vomiting. His CT scan shows a mass of 4 into 3 into 4 centimeters in head of pancreas. His pancreatic duct is also dilated.
थैंक यू। आपने पहले किए नहीं है? फर्स्ट अच्छा सही। तो ब्लू हाँ ये लगा हुआ है और उसको नीचे करके तो वाटर वाला पूरा दबाएं पूरा नीचे तक तो मेक श्योर देयर इज नो एयर और फिर अब जो सक्शन कर लें तो दैट विल बी पुल्ड आउट। हाँ इसमें इतना फ़र्क नहीं पड़ता पर अप रखें और ये अनलॉक है ना इनको अनलॉक रखें जैसा कि RCP तो यू कैन आर वी लाइव राइट नाउ हम लाइव अच्छा सही
Yes. We can hear you.
okay good so as you heard suspected cystic mass in the head of the pancreas so, कमरे की लाइट जरा डिम कर दें एक सही है गुड इसमें है पिक्चर पिक्चर के नहीं है
इसमें ये डायरेक्ट इसमें है तो डायरेक्ट इसमें
ठीक है
विमल लाइट बंद करो
नहीं कमरे की लाइट है
ऊपर हाँ ये और बस एक बंद करो ऊपर वाला बंद करो नीचे वाला खोलो वो
नहीं ज़्यादा लाइट है
ये कम कर वो
हाँ चलें
ये चलेगा या बंद कर दे
बंद ही कर दे मैं बंद कर दूँ अच्छा so what's your plan कोई नहीं केस के बाद थैंक यू केस के बाद सही है तो what's your goal here
big deal down ठंडा हो जाएगा
वह आप करना क्या चाह रहे हैं ये
ये लेफ्ट लोअर लिवर अप्रोच करें
ठीक है
और देन एओर्टा
सही है
and then celiac trunk
ठीक है
and follow the eccentric splenic vessels and then pancreas
ठीक है द एस सही है तो
liver.
लिवर ओके तो इधर से इसको पीछे करें रिलैक्स पीछे लाइक खालिद सेड स्टेप बैक अ बिट रिलैक्स योरसेल्फ एंड नाउ इफ यू गो लेफ्ट आर्म अप द होल स्कोप नीड्स टू मूव और बिल्कुल इस तरह तो यू विल स्टार्ट सीइंग स्ट्रक्चर्स तो अब वापस करें just to identify your structures so what do you see because this is nice that you're moving fast but what do you see here so go clockwise again okay so what was that
uh,
इसको फ्रीज कैसे अच्छा हाँ एक second. दोबारा हाँ ये वाला दोबारा करें जरा show me again right तो can you show me the aorta
this
good counter जाएं back the other way this right और ये आपके there you have your पॉइंटर कौन सा वाला बटन है इसका
धीमा हो जाओ बताओ
इसका जो पॉइंटर कहाँ से होगा नहीं 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 कि बस वो जो एरो नहीं आता
arrow
एरो
नहीं आता।
एरो कहाँ से आएगा नहीं नहीं
एरो
नहीं
एरो जो पहले ग्रीन वाला एरो आता था
वो कर्सर कर्सर
चलो चलो कोई बात नहीं मैं इससे कर लेता हूँ कोई बात नहीं तो ये आपका सीलियक है right? And this is your SMA. ठीक है? And this is your aorta. तो अब now if you go clockwise, एक चीज़ मैंने और करनी है कि I want to actually go this way ताकि ठीक है तो इधर celiac है अब इससे आप clockwise चलते जाएं so keep going clockwise and what's the structure
This is celiac trunk and
but what is this that's the left adrenal so that's not the celiac trunk तो अगर आप वापस जाएं counter so find your celiac again so that's it ये आपके फिर से ये देखें बेंड हो रहा है ना आप थोड़ा पीछे रहें डोंट गेट टू क्लोज टू द पेशेंट एंड गो क्लॉकवाइज लूज रहे और गो क्लॉकवाइज आपका स्कोप थोड़ा बाहर को आ गया दैट्स व्हाई वी आर नॉट सीइंग इट सो एडवांस इट अ बिट एंड नाउ गो क्लॉकवाइज कीप गोइंग ये आपका सीलिक अब so now if you advance a bit then you follow the celiac. So अंदर थोड़ा सा advance करें, keeping the celiac in view. तो आपका celiac तो हाथ से निकल गया, but that's okay because you're actually getting to pancreas. अब if you go clockwise, relax your big wheel because you're pushing on the pancreas. So relax your big wheel and keep going clockwise. And now you have the pancreatic body in view. And what you're seeing here is pancreatic duct which is dilated. अगर आप इसको measure करेंगे तो that's a dilated duct and you're also seeing side branches. Now go keep this in view, keep the duct in the middle and go clockwise. तो ये again आप you're tensing up. इसको छोड़ें, इधर से करें, इधर से support करें इसको. नीचे से.
Excuse me,
Yes.
sir, can you please point out the areas which you are telling him?
Sure, I am. I am
Can you please
actually-
freeze it and then tell us?
Yes, absolutely. So here is the pancreatic duct, and generally the rule is 3 millimeters in the head, 2 in the body, and 1 in the tail. And if we measure this duct, as you can you see you can see on the ultrasound left side it's measuring at 3 millimeters. So there is a dilated pancreatic duct. Now, if you go clockwise.
Endoscopically, he is in the body. We don't have a endoscopy.
Are you seeing? Yes, we're in the gastric. That was in the gastric body. So up under. No, pull back and go clockwise. I just want to show them what we're doing here. So now. So I'm going to pause there. So we are looking at the body of the pancreas. ठीक है? ये जो है, this is your celiac artery. Sorry, splenic artery, splenic vein, and this is the pancreatic duct that's getting compressed. Now, if we follow it clockwise, that looks like a very dilated duct. Go clockwise, up, counter that. That's it. Keep going clockwise. So you start following it, pull back. And that is your pancreatic. That is your pancreatic duct again, and it's dilated. Suction, because the air is getting in the way. So you're seeing dilated side branches on the pancreas. And the splenic vessels. Does that make sense? This is splenic artery, vein, go counter. Pushing करें. Splenic artery, vein, और फिर this is the pancreatic duct. Now go counter. That's it. No, other way. That's clockwise. Go the other way. Counter. That's it. Or keep going counter. So now we're going towards the patient's pancreatic head. Keep going counter.
pushing, pull back.
and then you push advance a bit, and now go counter. There. And now the pancreatic duct is markedly dilated here. Um, and it's cystic in appearance. But that looks like, and now, right. So it could be main duct IPM, or it could be obstructed. The other thing is we can put flow on it so that we don't get fooled. But clearly you can see that there's flow below in the splenoportal confluence, but here in the duct there's no flow. So we can take the flow back off, and now we have, I'm going to freeze it here just to measure, and you have a dilated duct in the neck area of the pancreas measuring up to 10 millimeters. ठीक है? तो let's go to the duodenum now. यहाँ से, I think that's mainly it, section करने. थोड़ा सा big wheel towards you, tiny bit. There you go. Now you're in the bulb. अब इसमें थोड़ा सा advance your scope a bit. Yeah. So now right there you have your bulb view of the bile duct section, and थोड़ा सा advance करें. You're pulling back a bit. There you go. So advance, and now go clockwise. So this is a markedly abnormal pancreas. Don't come back. Advance your scope and go clockwise. So there you go. So you have dilated cystic dilation in the pancreas, multiple cysts, and now go counter. All of this is cystic dilations, and it's going to be hard to make out bile duct from pancreatic duct from this view. But you already know that there is significant abnormality in the pancreas because there are all these dilations. So now we need to know what's going on at the bottom of the duct towards the papilla. But these are all dilated branches within the pancreas. Somewhere in there we may have the bile duct too. So let's go to the second portion. So look endoscopically. It's just like ERCP, right? So you've fallen back, which is okay. So there, good. Now that's it. Advance gently and then turn to your right. Good, very good. And then big wheel is towards you, right? So he may have a deformed duodenum, which may make it hard for you to get into position. So if you're falling back, try one more time. So now, very good. So now you can reduce. And here, typically what I would recommend is turn your body this way and pull back your scope a bit. Right now you're going to face the anterior wall if you look endoscopically. So pull back a tiny bit and go turn your left hand slightly to the left. So you move towards the medial wall. Thumb down with the big wheel, so big wheel towards you. And then you have your mesenteric vessels or aorta. And now you gently pull back on your scope. And now with your left hand, you're going to do counter or clockwise, and that'll give you your ancillary view. So isko support it with your right hand and gently pull back and then go counter and then go clockwise. Big view actually, thumb down. So yeah, I think you need to go more counter. Or You may be falling back a bit. That's the papilla coming into view now. You see that endoscopically? That means you're beyond it. So you're on the right track. So go clockwise, pull back your scope more, pull back some more, and now go counter. That's your unsnit, that's your pancreas coming into view. Now go counter with your left hand. Yeah. That's it. Support gently. Ab ye कि if you're not getting movement with that, you can use the shaft with your right hand and do countering clockwise with that too. That's it. अब इसको और counter करें because counter. There you go. अच्छा अब now this to bring this into view you have to pull back your scope. So pull back a bit, go clockwise. That, and then go counter. So that's your dilated pancreatic duct. Now you're about to fall, so just be careful. Now you just fell from the bowel to the stomach, but that's your pancreas. Let me do this part for a second. But that's the idea, that two things. एक तो ये कि bulb में जाके we are going counter towards the liver. There's the gallbladder. Look at my hand. It's all the way down, pointing towards my feet. So this is our gallbladder. That's the right lobe of the liver. And now I'm going to go clockwise, gently advance, and then I have my bile duct and pancreatic and portal vein in view. To confirm that I have my bile duct, I'm going to put flow on, and the top structure does not have flow in it, so that tells me that's the bile duct. So now I can follow the bile duct towards the liver, like that. That's going into the liver. And as I go clockwise, I can try and follow it towards the pancreas. As I do that, it's getting very close to the pancreatic duct or a cyst in the pancreas which is dilated. So I lose visualization of it. Right there. So, but there are multiple cysts, no discrete mass. So the question becomes, is this IPMN or not? But based on the appearance of the dilated duct, it looks more concerning for a neoplasm than a serous cyst adenoma. इसमें दूसरा है कि we want to look at the papilla to see the appearance of that, if there's at all of this fish mouth appearance. And endoscopically, I'm not seeing that. You did really well. This is an unstable scope position. So I'm going to get to the level of the papilla, push in a bit, and suction, and then look for the pancreas. My suspicion is that this is the main pancreatic duct, which goes from papilla area up this way. And then if I go clockwise, I have a cyst towards the unsnit. And if I go counter, the duct goes up towards the right. And then maybe the one above is the bile duct. So this may be bile duct and that may be pancreatic duct. Or this could be a branch of the pancreatic duct. I don't see an obvious solid mass. And this here is not true intraductal filling. This is artifact inside the cystic lesion or the cystic duct.
Both CVD and pentaric are dilated with the distal part.
Yeah, it could certainly be, but overall this appears to me like an IPMN. But one of the high risk sort of features would be bile duct dilation because it may be starting to cause obstruction of the bile duct. Then again, let's just double check with the bile duct. This, we're looking at it from the stomach. So this is SMV. This is that view where you look at the uncinate from um, from the gastric entrance. So you have confluence, SM, let me just point out things here. So you have confluence here, portal will come back this way, SMV will be here, SMA will be behind it, and this is the pancreas area here. And then splenic will go this way. So there's SMA, and if you want to confirm it, one can do the So this is the arterial waveform, and then behind it is FMV, and that'll be the venous waveform. And again, so that confirms our, clinical impression. And behind that is this complex cystic mass that is concerning mostly for IPMN. And if I was to decrease my depth and freeze my image, and in terms of measuring it from here, so 4.6. It is somewhere here. It may be from here. It's not clear to me how far it goes back here, but 4.7 by 3.1 roughly. And then this is the dilated pancreatic duct in the body, crossing. This is the splenoportal confluence crossing over and getting into the area of the lesion. This appearance here right here is concerning for solid component in the lesion. So I think this, I wouldn't necessarily sample this because it's not going to change the management where the patient likely needs surgery. And again, the other thing to do with these things is you can put flow on them to see that if there's flow within the lesion itself. And you can see that there's some flow. Again, it can be deceptive. It could be normal pancreas with flow in it versus the actual neoplasm. लगा था कि I saw some lymph node. ये जो है pancreatic duct हो गया, celiac, so yes, celiac. And then what I was saying was celiac, you push in to follow celiac. And as you push in, it starts branching into the splenic. And as you follow the splenic, you will start seeing the pancreas right there. इसके बस नोट देख लेते हैं, but I don't think कि कुछ और करने की ज़रूरत है.
With such a lesion,
Mhm.
has
Lymph node, and then you should look at the liver as well. Absolutely. Let's get rid of that. And the node, of course, in this region may be inflammatory versus truly neoplastic. The other possibility is a serous cystadenoma, but it just doesn't look like a serous cystadenoma to me. So for liver, you should do this, but basically get into the stomach and come down, like bigly towards you, and then you just go counterclockwise.
Sir, Dr. Mustafa,
Yes.
can you hear us, sir?
Yes. Go ahead.
We are few observers over here as well.
Sure.
So the request is, can you please, the stations which you just mentioned, can you please stop on those stations and freeze and tell us? That would help us a lot, because we don't have any hands on.
Oh, sure. So generally, I'll be honest, I don't remember the numbers of the stations, but I know the areas that you stop at, and you figure out where you are and look for lesions or structures. So in the stomach, as you come down from the mediastinum into the stomach, you're following the aorta. And the first structure you want to look at is the two arteries, the two main branches, which are the celiac artery and the SMA. The aorta runs this way. If from here, if you go, I don't know if you can see my hands, but if you go clockwise with your hand,
We can see you. We can
okay,
see
good.
you.
That takes you towards the patient's left. And as I go clockwise, you can see the seagull structure there, and that is the left adrenal. So whenever you have celiac, go 90 degrees clockwise, and you should run into the left adrenal. So from there, if you keep going clockwise, you'll see left kidney, and then the spleen will come into view. So that pretty much is your evaluation of this part of the from the stomach. You've got your spleen, you've got your celiac, left kidney, and then you're back to the first spot, which was the celiac. From here, as you push in, gently advance your scope, and you start seeing branching of the celiac. And I'm going to just pause it there. This is the celiac branching into the splenic artery, and the hepatic artery is going to go downwards on this view. Okay? So as you see the branching of the artery, then you advance the scope a bit more, and generally that will bring you to your pancreas. So now all I did was I advanced it gently and went slightly clockwise. And now you have your body view. So you have your celiac artery, pancreatic duct, and splenic artery, pancreatic duct, and splenic vein. As you go, once you have your pancreatic duct in view, and I usually like to actually make my pancreas image bigger, and and then follow it. So then, moving the cursor away, as I go clockwise towards the tail, I'm following the pancreatic duct towards the tail.
This is dilated pancreatic duct, isn't it?
Exactly, I was going to say. So the rule for the pancreatic duct generally is 3, 2, 1. 3 in the head, 2 in the body, and 1 in the tail. here we're reaching the tail, and even if we say that some of this is a convoluted duct, if I measure it here to say even here, it's already 2.7. So the duct is dilated in the tail. As I keep going clockwise, I'm following the duct towards the tip end of the tail, and generally speaking you have to pull back a bit as you do this till you're convinced that you have evaluated the entire pancreas where you lose it, and that usually the spleen comes into view. So that's my body to tail view. Now I've gone clockwise, so if I do the opposite, if I go counterclockwise, then I should have the tail to body view coming into view. And as I keep going counterclockwise on this, again, just for a reference, right there, splenic artery, vein, pancreatic duct. We're going counterclockwise now, and as we go counter, the pancreatic duct all of a sudden becomes quite dilated here in the body. So here it's massively dilated. And actually what's going on is we can go down on our depth. It's dilated and it's dipping down from left of screen to right of screen. And what it's doing is it's crossing the splenoportal confluence. So here it can be confusing, am I following duct or am I following vessel? And you can easily put your flow on and you can see duct above and vessel with flow right there in the lower half. So just for sort of clarification. This is your pancreatic duct, markedly dilated. That's your portal vein, and that's going to be your SMV, and splenic vein is going to go this way. Now if I take the flow off and I advance a bit and go clockwise, I can see the splenic vein now going, this is the splenic vein. And if I go usually clockwise, you can see the splenic artery, which we had earlier, sorry, the SMA, but right now I can't seem to reproduce it. But what you can also see is that not only do you have the pancreatic duct in the body, but you can actually appreciate that in the head area, because of this abnormal pancreas, that this cystic area in the head, you're seeing from the stomach. So the uncinate cannot be visualized from the bulb usually. You either see it from the third portion or you see it from the antrum of the stomach in this view. So there's, by the way, the SMA. This is SMA going in this way, and then you'll see the splenic vein going this way. And this is the lesion right here. So that's the view of the head of the pancreas from the stomach. Now come the duodenal stations, and again it's a personal preference thing. I like to do my duodenal evaluation on the way in. So I will typically get through the bulb, the pylorus, see my duodenal mucosa, suction, and typically drop my left hand towards the liver. And as I do that, sometimes I'll run into the gallbladder like here. So that's the gallbladder. And again, if in doubt, because your IVC is going to be posterior too, you can put power, oh, I'm sorry, wrong one. You can put flow on it and there is no flow. So this is the gallbladder. As I go clockwise and advance my scope a tiny bit, it'll bring me to the portal triad. And this here is the portal vein and the bile duct. This is that view in the bulb. You're looking up towards towards the liver. So bile duct in front, portal vein going towards the confluence in pancreas. And to prove that this is bile duct, we can again put flow on, and there's no flow in the structure above, whereas there is flow in the structure below. So that's your duodenal bulb view of the bile duct. Here what I like to do is keep the bile duct in view and follow it into the liver like that, and then go clockwise and follow it towards the head of the pancreas. In him, it's you run into the pancreatic cysts, but my impression is that this is the bile duct. There's, even though this looks like there's no communication, I think there's separation between the two we're not seeing. And that is the pancreas with the cyst in it. Right there is the wall between the two. Right there. And as you go clockwise, the bile duct will go down further. But with all his pancreatic head cysts, it becomes very hard to differentiate. So this is now looking at the head from the bulb. So we're still in long position in the bulb, now down towards the feet. So as I remove my cursor, as I go counter, I can again, I should be able to in most cases find the bile duct again. Right there. So again, bile duct at the top, and then pancreatic duct at the bottom, portal vein at the bottom. So now from here, I will usually use my endoscopic view to try and determine what the best approach is to the second portion. But typically it's big wheel towards you, gentle advancement, and then usually you can see the second portion by now. In him, it's not obvious, so I'm doing slight small wheel to the right and gently advancing some more. And here, now I see the duodenum, second portion, so I'm going to go thumb down on the big wheel, small wheel to the right, and gently just reduce the scope. As I do that, we'll get shortened into the second, third portion. This is where, even though in the books there's a distinction between the first, I guess the first and the second stations, for all intents and purposes, I actually use a combined approach. And typically what I will do is, with a Pentax scope, because it's a big scope, I can get next to it and start evaluating the uncinate right away. But with the Olympus scope, I'll usually pull back a tiny bit, look for the papilla endoscopically actually. I see the papilla there. Iski brightness is a company. Okay, that doesn't look very normal to me either. There may be some degree of inflammation in the area of the papilla. But I have the papilla in view. My probe is distal to my endoscopic view. So now I'm going to put my balloon up a bit. You don't have to do this, but in this situation I am, because there's a distance between me and the medial wall of the duodenum. And I go clockwise. And then I gently go counter and start evaluating the pancreas. If I go clockwise, it'll be towards uncinate. And if I go counter, I'm coming towards the bile duct and the pancreatic duct. And as I do that, I will gently pull back. So there's your uncinate again. There's your SMV and SMA. And here's pancreas.
We don't have a EUS image. Can I EUS image laga do? Thank you.
Oh, आपको तब से था या नहीं है?
No, no, we had it. We just didn't have it for last few minutes. So what type of cyst is it?
Ultrasound image नहीं आ रहा. I personally think it's an IPMN. I'll show you. It could be a serous adenoma, but the degree of main duct dilation in the body for me is concerning, and I felt that there was some suggestion of solid component within the cystic lesion.
And looking at the body and tail area, there is some atrophy.
Yes,
Yeah.
which I think with the dilated duct, I would expect the tail to have.
Yeah.
But this is the cystic lesion.
It doesn't look like a simple cyst.
It's, oh no, not at all.
Yeah.
It could certainly be a serous adenoma, but again, my biggest concern is for an IPMN that's undergone conversion.
Yeah, so if it was a serous cyst adenoma, we wouldn't expect that much of a main duct dilation.
Exactly. So that's why it makes it less likely.
Do you think
But-
we need to do FNA?
You know, we can certainly consider FNA of one of the distal cysts. Here, the concern for me would be, it's hard to differentiate main duct from a side branch. I think I've fallen into the stomach. But if the goal is to get fluid for cytology, we could, though I don't think it would necessarily change our management. With this size and this degree of
So,
pancreatic duct dilation,
so what management we are talking about?
surgical.
How much? Total pancreatectomy?
Well, they usually, in this kind of thing, it's a good question. They usually would take it all the way to the point of the dilation. Even though total makes sense, they try and preserve, at least at our center, they try and preserve part of the tail to reduce the risk of
Yeah.
significant diabetes.
Yeah. So the pancreas, the amount of pancreas we really need is 1/5 of the pancreas.
We lost you, Khalid.
Yeah. So what I was saying is like the amount of pancreas we need really is 1/5 of the pancreas, 1/4 to 1/5. So what they will try to do is try to preserve the most distal part of the
Exactly,
pancreas.
yeah.
Because the duct is okay in the most distal part. And
Exactly,
there
yeah.
is some pancreatic parenchyma there as well.
Yeah.
Because if you do a total pancreatectomy, I don't know the age of the patient. What's the age?
He's
एज क्या है पेशेंट मैडम
35.
Yeah, so he's gonna run into high risk of diabetes, and these are the patients who really end up getting islet cell transplantation. Yeah.
Which may not be. Now, Khalid, here I'm not necessarily convinced that this is a mass. To me, this looks like okay, but
And
it's
it doesn't look like a mass, and it's on
Yeah.
the side of it. It's
Yes.
not causing obstruction to the main duct.
right?
So that's actually a normal pancreatic tissue. I think.
Exactly, yeah.
Yeah.
And then with these cysts, sure, one could sample one, but
You know, what
I wouldn't be too keen on it personally. But
I think either way is fine. Because of his age and risk of surgery, it's going to require a much bigger surgery. I just want to make sure there's no cancer in here.
so send the fluid for cytology. Is your
Yeah, no, I will go after that thick septations in there and get some fluid from cytology too. So these thickened area, I will try to get some cells from that. That's what I would do personally. I don't know what they want us to do.
yeah.
But if he's going for surgery, then maybe.
Yeah, but that's the issue. That he's 35 and it's going to be a big surgery.
Yeah, so the downsides are potentially causing pancreatitis or a leak, right?
Correct.
So that's if obviously if there wasn't that risk, I wouldn't be hesitant about doing it.
It's a very complex cyst.
Yeah. See, I think in my mind, there's no way this would not require surgery. That's even given his age. If he was like that 17-year-old, I would be more inclined to say that, I wonder if this is truly a neoplastic process.
I think it is.
But with this guy, with this kind of findings, I think this is neoplasm, and it doesn't change. So my personal opinion is that we shouldn't, but if
No, I think if that way is fine too, but he needs to go for surgery.
yeah, I think so. I don't know if Dr. Niaz is there, or
No, I think we need to ask them if they want. I think I'll leave it alone.
okay.
And can you show the bile duct again? I want to show
Yes.
them. Can I have
Yeah,
the
yeah.
pointer?
So again, I don't know if you can see my hands, but my typical approach from the bulb is get through the pylorus and just stop. And then drop your left hand and go drop your left hand, advance a tiny bit, and go counter.
So
And-
you basically start from the hilar downward.
Exactly, because what happens is, for me at least, I've found that if I can get liver like this, usually when I go back into clockwise position and advance a bit, it typically brings the portal vein like that into view for me.
So here you see that's the bile duct right there. There is a
This, I'm compressing it. I'll put flow on and prove it to you guys.
So,
But this is
and
bile
that-
duct and that's portal coming down.
yeah. So what is this here? That's gonna be a like. Can you freeze there, please, for a minute?
Yes,
And put a Doppler on there.
sure. Give me a second.
Put the Doppler. You see there is no flow in this here, right? In this area. Anybody knows what that is? The duodenal wall, that's can you go towards the liver a little bit, make it, now this is not a duodenal wall, right? That's a gallbladder neck. Okay, so here you see it's going to start going. If you keep following that, you will end up in the gallbladder. So
You, what would you want me to do? Go towards pancreas?
can you move your big wheel a little bit away from you? Little bit, stay in that position. You see that? You see that? So that was a gallbladder and neck. So if you follow that big wheel away from you and rotate it towards the liver, you will end up in the gallbladder.
Yeah.
So actually, I wanted to show the gallbladder neck.
Oh,
so that,
sure,
yeah.
sure. Right there. I'll just have to reorient myself for the bile duct. But are you?
Yeah, we got that.
You
we,
got
we
that?
Saw, yeah, we got
Okay.
it. Yeah,
And
it's
then
good.
this is the bile duct.
Yep.
And I don't know if you saw that part earlier where, let me just take the flow off for a second, that as I then follow it towards, I'm extending so I can, big wheel is away, so I'm trying to move my probe away from the duodenal wall so I don't compress the bile duct. Otherwise I end up compressing it like that. So if I do big wheel away and I go clockwise, I'm hoping I can follow the bile duct towards the pancreas, which
So
now it's paradoxic actually, it's going towards the
here,
liver.
this is the left side of the liver. Left
Yeah.
side of the liver is on the top, and right side is at the bottom. If you
Yeah.
have to look at the left hepatic duct or the right hepatic duct, so you follow the left hepatic duct upwards, and if you want to follow the right, that's going to come down.
So there. So right where the arrow is the duct coming down, but then you lose it in the area of the pancreas. You can't see it very well. And then theoretically, if I, for the bile duct, if I go to that second portion view again and go counter, his duodenal positioning is somewhat unstable, but if I go counter, I should be able to follow bile duct. Here, differentiating it from the pancreas is challenging. Khalid, I think this is the main PD. All right, so we're gonna come out. आप liver देखें. So go ahead and. So basically, the liver, just for anatomic purposes, it's against this medial wall. Okay. So what you want to do is section. bring it towards you, go clockwise like this, and then as you go against the wall, and then as you spin and pull towards you, the liver should come into you. Okay, so that's the edge of the left lobe, segment 3, and segment 2 will be closer to you. So yeah. And then we should do mediastinum on the way out too. Good. That's it. And the rule is you go counter and clockwise till you lose the liver. So go counter, and when you lost liver, then you can stop and go the other way. Yeah, don't let go of that. If you've lost it, now go the other way. Now keep pulling back. Yes. So try and get better imaging on that. So pull back. That's your gallbladder, by the way, from the stomach. And now go clockwise. Yeah, see, this is what you don't want to do. You want to be totally loose, step back. Again, if you're a bit like shorter height, then just step back, relax this. Step back. There you go. Now spin your left hand. Use your right hand as a fulcrum. All it's doing is it's supporting the scope, or sometimes it's helping with this. But go counter. So let me just show you one thing here. You'll do this, but there's a lot of this, and that's not doing anything. If you just straighten your hand and do this, then look at how much movement the scope's doing. And this is really just to support it. So this and this. The minute you do this and then you do this, your scope movement goes away. So you have to relax your left hand, keep it in neutral position, and then do this. If you think that you're not getting good apposition against the wall, then use your thumb against the thumb down. Again, relax. There's my liver. All I'm going to do is go counter, go clockwise till I have it. Now I need to pull back a bit, go counter, go clockwise. All I'm doing with my right hand is really just supporting the scope. But all the work is actually coming from a relatively straight right hand, left hand, sorry. So this is all I'm doing. Right? So I want you to try and do that. So again, advance, find your liver edge. This should be like that. Okay? Not like this, not like this. Okay. Try that. And again, keep your distance from the patient. Section. Yeah, and then support from here, from the angle. There you go. And all you're doing is supporting it. You're not necessarily holding it even. There you go. Good. And now go counter more. Now pull back because you're on the edge, right? So pull back. Yeah, that's it. Keep going counter till you lose it. So keep going counter all the way till you lose it. Keep going, keep going, keep going. See, because if you don't go counter, you're going to miss something, right? So if you really want to evaluate the liver, keep going till you lose it. When you've lost it, then you can keep going counter. You're stopping too short. Keep going, keep going, keep going. Now you lost it, right? Now you don't see liver. In fact, you see spleen. So now you go clockwise again. And now you go the other way till you lose it, right? The whole idea is not just to see the liver, but to evaluate the liver for lesions. So again, now you pull back again and do the extreme till you lose visualization of the organ. But you're not going clockwise enough. I want you to go all the way clockwise. All the way till you see maybe IVC or something. No, keep going. See, there's more liver. See? Keep going. Now you can stop. Now you can turn back. So it's almost like 270 degrees. But that's what you need to do. Okay? Okay, good. Keep coming back. Keep coming back. Yeah, but clockwise counter. Because the idea is to evaluate it. Here's a little node up there, but that's okay. Keep coming back. Because I want you to do mediastinum now. Okay. So now you have to identify your mediastinal structures, right? So that's it, stop. Now go counter. What's that? Go clockwise. And push in. Where is that vessel going into? Huh? Sorry, I didn't hear you. Into the, what's this? You were just looking at it.
This is the ventricle.
This is the liver, right? So this vessel, you had it here, you pushed in and you went into the liver. So what's going to come to the mediastinum from the liver?
Anterior.
Exactly, IVC, very good. So come back, pull back. Okay, now go counter. You're spinning again. Spin. Go clockwise, go counter. Okay, looks like there's something pulsating here. So let's look at this. Pull back. Okay, now spin your. Okay, now we're starting to see maybe the heart. So go counter, counter. There you go. Okay, there's your excellent. That's your view. Left atrium, left ventricle. Aorta is going to come up here. Okay. If you pull back a tiny bit more, good. And now spin here, left and right. You spin. There's your aorta, right? Go the other way. Go the other way. Go counter again. There's your aortic valve.
Yes.
Up here, sorry, is going to be your subcarinal window. So pull back a bit, and that's where you would see nodes. This might be, that's a node in the subcarinal region, right there. It's triangular, and it's not a very high concern. We'll all have nodes in that area. So now come back. So that's your subcarinal. Keep following the aorta if you can. So go clockwise, go counter. That's your trachea. So when you see that shadowing, that's your trachea. So pull back. There you go, your trachea. Now go clockwise. Keep going clockwise. See, that's your aorta. Keep going. Keep going clockwise. Find your aorta. There. So let me show you. 8 seconds. So basically, that was pulmonary artery. That's your aorta. Aortic arch. Thumb down, clockwise a bit, push in. And that's your level 4 left lower lower paratracheal. Aorta, pulmonary artery, lymph node, and that's it. We're done. It's at a cough. Sorry. Thank you. ठीक है? हाँ नहीं, no problem. The cases है कि pathology है ना, तो इसलिए makes it challenging, but that's how you learn. हाँ जी मैं आपको लिखा हूँ.
लेकिन ओके टाइप
बस बाबा हो गया खत्म.